All right, welcome back for the fourth and final lecture for the histology of the male reproductive system. And in this lecture, we're going to be talking about the seminal vesicle, the prostate gland, and the male urethra, covering both histology and the relevant physiology. And at the end, we will cover some relevant clinical pearls. All right, so in the last part of this lecture, we're going to talk about the male accessory sex glands. So the seminal fluid, or the semen, it's composed of sperm and then secretions from the accessory sex glands. And those in the male are the seminal vesicles, the prostate gland, and the bulbourethral glands. And we'll go over each of those here over the next few slides. So first, you got the seminal vesicles, and we've already mentioned these when we talked about the formation of the ejaculatory duct, but just again to review, it's a pair of tubular organs that are on the posterior aspect of the bladder, as you can see here, just superior to the prostate. And they send out a secretory duct that converges with the ampulla, or the terminal portion of the vas deferens, to form the ejaculatory duct. And again, the purpose of that is so that the seminal vesicle secretions can converge with the sperm coming from the testicles. The seminal vesicles, they're composed of a highly folded mucosa, and it depends on what source you look at. Generally speaking, it's a mixed, simple columnar epithelium. Some sources may say it's a pseudostratified columnar epithelium, and that's one where you're just going to have to go off of whatever the major source is that your professor's using, mainly the slides that they're using or the book that they are referencing. It's not entirely clear what the consensus is, but again, it's generally just a mixed simple columnar epithelium is the way you want to think about it, or simple columnar epithelium. Around the mucosa is loose connective tissue with elastic fibers to help provide support for the mucosa. The secretions are carried by the secretory duct, which merges with the ejaculatory duct. And again, here's a cutaway of the ampulla portion of the vas. And again, this is coming down here, carrying sperm. You can see it's nicely cut away. Here's the ejaculatory duct. Here's where you have that junction of the secretory duct coming from the seminal vesicle. And so that carries the secretions, and then they merge here to form the ejaculatory duct, which then goes on to merge with the prostatic urethra, as we talked about. So the secretions from the seminal vesicle, they contain the following elements. They have the fructose, which is actually the main metabolic substrate for sperm. A sperm actually needs a lot of energy. It has, as we talked about, a layer of mitochondria, and a lot of that is to help power the flagellum, which will help propel the sperm forward. And so you need fructose to help provide the energy, and that's the main substrate for sperm. Also has ascorbic acid, prostaglandins, amino acids, and proteins. These secretions are viscous and alkaline to offset the acidic environment of the female reproductive tract. So all of these elements are both meant to support and power the sperm, but also to protect it in the environment of the female reproductive tract. The seminal vesicle secretions, they comprise about 50 to 80% of the ejaculate volume. And the growth and function of the seminal vesicle mucosa is actually stimulated by testosterone, just like how the mucosa of the prostate gland is also stimulated by testosterone. The outer wall of the seminal vesicle contains a thin, smooth muscle layer that actually contracts during ejaculation. And then around that is the entire organ is actually surrounded by a capsule. So to just show you some quick histology images, again, we'll get more into this in the lab video, but here's a very zoomed out view of the seminal vesicle here. You can see the mucosa here surrounding the different lumens. And then you have, as we indicate here with this white bar, a muscular layer surrounding that mucosa. And then again, arrowhead indicating mucosa here. We zoom in, you can see this smooth muscle layer right here. And then you can see this arrow pointing to this mucosa or epithelium layer here. So if we further zoom in on the epithelium layer, like we said, it's a highly folded mucosa. So you can see these folds here. It's indicated by the arrow here. We zoom in here, again, significantly folded. One way you can tell the seminal vesicle from the prostate gland is looking for prostate concretions. And as it is in the name, those are only found in the prostate gland. And we'll show you what those look like in a few slides here. But kind of one quick way to kind of rule out that it's the prostate gland, or really rule in that it's the prostate gland. If you see prostate concretions, that's it, you're done, it's the prostate gland. If you don't see them, then it's maybe a little bit more difficult to determine. And again, we'll go over these more, the differences, the histological differences in the lab video, and then in a second here when we talk about the prostate gland. So the prostate gland is the largest male accessory sex gland. And as we've mentioned before, it's located inferior to the bladder, as you can see here in this diagram. And it surrounds the prostatic portion of the urethra. Like we said in cross section, here's the urethra traveling through the center, and you can really appreciate that here. And then it's composed of numerous tubuloalveolar glands that secrete prostatic secretions into the prostatic ducts, which then drain into the prostatic portion of the urethra. So if we look at a cross section here of the prostate, you have these different glands surrounding it, like that. And then they have these prostatic ducts, which are these kind of very tiny ducts that drain the prostate, these gland tissue, carrying the prostatic secretions into the prostatic urethra. And remember, in cross section here, you have the ejaculatory duct, which is carrying, so you have secretions from the seminal vesicle, and then you have this kind of widened portion here of the vas. So you have the vas deferens carrying the sperm. And so you can see really here in cross section where it all comes together. So you have the vas carrying the sperm from the testicles, the seminal vesicle secretes their secretions, everything merges into this ejaculatory duct, makes its way to the prostatic urethra, and then you have the prostate secretions making their way as well via these prostatic ducts. Now, the glands of the prostate are arranged concentrically around the prostatic urethra, like I've mentioned, and they're actually separated into these different zones. You don't need to memorize the exact borders of these zones. You just need to know the general idea. They can kind of come into play when you talk about the clinical pearls that we'll mention, specifically prostate prostate cancer versus benign prostatic hyperplasia, which we'll outline at the end of this lecture. So if we kind of just draw a rough diagram here, here's the bladder. And then again, here's the prostatic urethra traveling in here. And if we draw the prostate gland around like this. Now, the first zone or region is the periurethral glands. And again, it's in the name, they just surround the prostatic urethra. So these are just outside the urethra here. So we'll kind of draw this part in here. Kind of just shade it in a little bit for you. And so this is your periurethral area. Then you have the transitional zone. Now the transitional zone is kind of, again, it's a transition from the periurethral to the peripheral eventually, which we'll talk about. And then it's kind of this region like this, just outside that. And then lastly, you'll have the peripheral region out here like this, which again, it depends what source you look at as far as how well these are demarcated. But again, this is the peripheral. This is the transition. Now you may be wondering, what's all of this tissue up here? This actually, there isn't much gland tissue up here in the more superior aspect of the gland. This is what's called the fibromuscular stroma, which is essentially supportive tissue, connective tissue, some muscle. And this is meant to just support the gland. It's not actually, the parenchyma, the functional gland portion of the organ. So this is more supportive tissue up here in this aspect here. So again, to review, you have the periurethral, which is surround, then you have the transitional, which are the submucosal glands, and then you have the peripheral or main glands out here on the edge. So the glandular tissue, like I said, is surrounded by a fibromuscular stroma, which is that supportive tissue, and then the entire organ is surrounded by a thin capsule. The prostatic secretions are water and acidic, and they contain the following. They have proteolytic enzymes such as fibrolysins that liquefy the semen and citric acid. They have prostatic acid phosphatases and serine proteases that include prostate-specific antigen, also known as PSA clinically. This is actually considered a biomarker for essentially the stimulation or growth of the prostate tissue, and so is actually measured as an early indicator of prostate cancer. So if someone has a sky-high PSA, the next step is to think about maybe getting a biopsy, or at least first doing a prostate exam to see if there's a mass. And then if there is a mass, if there's a palpable mass, then you can do a biopsy and see if it's cancer or not. So it's not a definitive diagnostic marker, but it's something that kind of piques our suspicion for prostate cancer and can be an impetus for further investigation. Testosterone is actually converted, see if we have T here, testosterone, into dihydrotestosterone, or DHT, which is a more active molecule, essentially a more active version of testosterone, and it's converted via this enzyme, via alpha reductase. And so this DHT actually stimulates epithelial growth and secretion of the prostate gland. A histological marker of the prostate gland, like we mentioned, is prostatic concretions or corpora amylacea, and these are found in the alveoli of the glands. Here's a great image. It's indicated one here by this star. You can see the tubuloalveolar look of the gland tissue here. Kind of more of a simple cuboidal type epithelium that lines these, not quite as folded as the seminal vesicle. And then obviously you have the prostatic concretions here as well, which is pathognomonic histologically for the prostate gland. So the last of the male accessory sex glands are the bulbourethral glands, also known as Cowper's glands. And these are small glands about the size of a pea, and you can actually see them. You see here in this diagram, they're labeled Cowper's, and it's this little pea structure right here. I'll draw an arrow pointing to it. And see how it has this, it's just inferior to the prostate here, and it has this little short duct that then connects into the proximal part of the penile urethra, actually here at the base of the penis. So that's where it provides the secretions via those short ducts that I just pointed out. Histologically, they're composed of tubuloalveolar glands, and they produce a viscous alkaline secretion that's high in galactose, and that helps lubricate the urethra and then protect against the acidity of the urine and the female reproductive tract. And then the male urethra, just very briefly, we'll touch on this again. Remember, we went over this pretty extensively in the urinary system lectures. But again, just remember the epithelium actually changes throughout the male urethra because it has these three segments. It starts out in the prostate urethra where it's transitional epithelium, just like how you have in the bladder and the ureters. Then it eventually transitions into the pseudostratified columnar epithelium, and that transition occurs in the membranous segment of the male urethra. And then eventually, as it gets out towards the more terminal portion here near the orifice where you have the skin, it actually changes into stratified squamous epithelium at this very terminal end here because you're continuous with skin tissue there. And so remember, you have the prostatic segment, which is here, and then you have the membranous segment, which is from here to here. And then lastly, you have the penile or spongy segment that continues on through the penis and is the last segment. So the penis in the male is an external sexual organ, and it is the outlet for both urine and then the ejaculation of semen. The shaft of the penis consists of 3 cylinders of erectile tissue, and you can see this spongy-like erectile tissue here in this cross-section of the shaft of the penis. And so those 3 cylinders, you have 2 corpora cavernosa, or the corpora cavernosum, which is the singular, and that's these 2 sections right here. And then you have 1 corpus spongiosum, which is down here in this aspect here. This would be the ventral surface of the penis, and this would be the dorsal, or essentially the top of the penis here. That stems back to embryology and standard anatomical position. All 3 cylinders are encased in a dense connective tissue layer called the tunica albuginea. And so that's what holds the structures together. And then outside of the tunica albuginea, the shaft of the penis is covered in a layer of hairless skin that's continuous with the scrotum. It contains sebaceous glands, and then it forms the prepuce, which is a fold of skin that covers the gland's penis at the tip of the penis in uncircumcised males. So a circumcision is a surgical procedure that involves cutting away some of this fold of skin. As we mentioned before, the penile urethra, as it's in the name, this section of the male urethra travels in the corpus spongiosum. You can see that here. Here's the cavernosum here, this white section here. And then this section here with the urethra traveling through. This is the spongiosum. And then the glands of Letrae are these simple acinar exocrine glands that are found in the spongiosum that have these short ducts that secrete mucus into the penile urethra. The secretory acinus is composed of either a simple cuboidal to columnar epithelium. No exam is really going to make that distinction between cuboidal and columnar. It's really, you're just going to be asked to identify it. And so with that, you just got to know that it's a section from the corpus spongiosum or the penis. And we'll show you that in a couple slides here, and we'll go through that in the lab video as well, how you will know that. You're just looking for glandular tissue in that section. The corpus spongiosum forms the glans penis distally, so you can see it's labeled here. So that's this terminal portion of the shaft of the penis here, or this terminal portion here. And so as you can see, this is a nice diagram. It's continuous here. This spongiosum is just continuous here into the glans penis. The glans penis is actually where the penile urethra transitions to squamous cell epithelium. So remember, in the more proximal portion of the male urethra, it's actually transitional epithelium, just like how you have in the bladder. And then it transitions in the more proximal portion here to pseudostratified columnar epithelium. And then all the way down here in the glans penis, it makes that final transition into stratified squamous epithelium. And that makes sense because this portion here is continuous with the skin, and remember the skin is stratified squamous epithelium. The corpora cavernosa, which again, if we label this here, here's the cavernosa, these two cylinders here, here's the cavernosum here, and you can see with the urethra labeled. The cavernosa contains a complex network of venous sinuses. So although you have erectile tissue in here, the bulk of the venous sinuses that are responsible for an erection are located in this sections here. And during an erection, these veins, they dilate, both in the cavernosa and in the spongiosum, and they become engorged with blood, and that's what gives you an erection. So the autonomics of this, it involves actually the parasympathetic nerve fibers, sympathetic nerve fibers, and actually somatic. Remember, these two are part of the autonomic nervous system. So the parasympathetic fibers, they stimulate relaxation of smooth muscle in the blood vessels in the corpora cavernosum and the corpora spongiosum. And then they dilate as a result of that, and that causes the erection because they become engorged with blood. And so that's parasympathetic portion is responsible for the erection, and then the sympathetic and somatic nerve fibers are responsible for ejaculation. So the sympathetic nerve fibers stimulate contraction of the smooth muscle in the ejaculatory ducts, pushing the sperm and ejaculate secretions into the prostatic urethra. And then you have these somatic nerve fibers that are traveling through the pudendal nerve, which if you're taking an anatomy course, this is relevant. If you're just taking histology, this is just kind of extra information. These can be frequently a test question on anatomy exams though, so you may want to pay attention to that. And particularly its perineal branch stimulates relaxation of the external urethral sphincter, and then also stimulates contraction of the bulbospongiosus muscle. Again, this is relevant if you're taking an anatomy course. Otherwise, for histology, this is just extra information. And that compresses the urethra, leading to propulsion of the ejaculate. So here's a histological section from the penis. This would be from the corpus spongiosum. And so you see all these kind of venous structures here. These are the veins, the cavernous veins that get engorged with blood, and we'll zoom in on those on the next slide. Here's the urethra here. So this is the lumen here. You can see it kind of has this very irregular shape. If we zoom in, you can see the epithelium by this white arrowhead is that pseudostratified columnar epithelium here. And then the white arrow here is pointing towards one of these venous cavernous spaces. So remember, these will dilate and become engorged with blood during an erection. All right, so to close this out, we'll talk about a few clinical pearls. These are actually very common diseases seen in the male population, especially the older male population. So first, the benign prostatic hyperplasia. As it says in the name, this is a totally benign process. It's extremely common, especially in older men, especially men over the age of 60, 65 years old. It gets even more common as you get older than that. And again, like it says down here, there's no malignant potential. This is totally benign. It can't transform into prostate cancer. Prostate cancer is a totally different process, as we'll talk about on the next slide. And it's hyperplasia of the stromal, or that supportive tissue, and the epithelial cells, mainly within the middle and the lateral lobes around the prostatic urethra, the periurethral zone, as we talked about when we talked about the prostate. So if we draw the prostate out again here. Now, the lobes aren't terribly important or terribly high yield at this stage. They're just helpful to kind of differentiate these clinically and kind of help explain the differences in clinical manifestation of both BPH, as this is known by, and prostate cancer. So if you have the urethra here, and I'll put an X through that so you know it's not a lobe. So that's your urethra. You have your anterior region here. You have your posterior region here. You have your middle region here, which is just by the urethra here. So we'll do mid for there. And then these are your lateral. This is lateral as well. So it's in mainly the lateral lobe and this middle lobe around the urethra here. Now, by being around the urethra here, let's say this hyperplasia continues to grow and grow and grow. As you can see, it can press on the urethra and cause compression of the prostatic urethra. And this results in the common clinical manifestation of BPH, which is increased frequency of urination, because you're essentially causing some resistance to urinary flow, nocturia. You often hear of older men having to get up in the middle of the night and go to the bathroom, sometimes with significant frequency. Difficulty with starting and stopping urination because you have the muscles here contracting and you have compression going on, and that's again causing resistance to flow. It can get to the point where it actually almost completely compresses down and causes severe urethral obstruction. In that case, this is pretty significant. This is where you actually have to have surgery or have surgical evaluation at least, because it can lead to hypertrophy of the bladder because the bladder is contracting. Remember, the bladder is a big muscular bag at the end of the day. And so to press against this resistance, the bladder's got to continually gain more strength and more muscle mass to compress against this. And then it can even back up to the point where you have hydronephrosis, which is in the name hydro, and the nephro, which is kidney, so water kidney. So again, if we draw the kidneys like this, and remember they're kind of these bean-shaped structures in the abdomen, and then you have the ureters that come down like this, and then you have the bladder like this, and then you have the prostate and the urethra here, and the urethra comes out there. So if you've got obstruction here because of significant BPH, one, the bladder has to contract it harder against that. It's the same thing when you have like aortic stenosis. You have resistance against the heart, compressing against higher peripheral vascular resistance. It's the same concept here. The bladder has to compress against higher resistance here because there's essentially significant occlusion or even complete occlusion of the urethra. And then what happens is that it's just like blocking a pipe anywhere else. You're going to have backflow of fluid all the way, potentially, if it gets bad enough, up into the kidneys, and then you can have, water retaining in here, and that's where you get hydronephrosis. The other thing is when you have any type of tube, and this is no exception with urine, if you have an occlusion like this, any type of fluid like this that should be exiting the body, you have a risk for infection because bacteria can get caught up in here and grow and then colonize and cause a significant infection. That's true for a lot of different bodily fluids like bile, urine, things get blocked up, mucus in the lungs. For example, that's why patients with cystic fibrosis get such recurrent infections because they have blockage of flow. And then all same thing with patients that have like ciliary dyskinesia in the lungs as well. It's the same type of concept. Same concept here. When you have obstruction of bodily fluids, it's a potential source of infection. So PSA, or prostate specific antigen, like what we talked about in the prostate gland lecture, it's often elevated due to hyperplasia of gland tissue. So it's going to be high in patients with BPH. It's frequently seen that patients, especially older men, have a high PSA, but it's often not as high as it is in cancer. So like I said earlier, PSA, it's a helpful marker. It's especially helpful if a man is good about seeing their primary care doctor on a regular basis and they get their PSA measured on a regular basis, because then you can establish a baseline. Because sometimes just a baseline, maybe due to their BPH, they may just have a high PSA and it's nothing to worry about. However, if that baseline were to jump on a PSA measurement at some point, then you may be concerned for prostate cancer if it increases significantly. So as far as treatment goes, you can give 5-alpha reductase inhibitors, which, remember, testosterone T gets converted into DHT, which is a potent stimulator of hyperplasia of the glandular tissue. So if you block that, that helps cut down on the stimulation of the glandular growth. The other thing you can give is alpha-1 antagonists. This is actually the drug Flomax. You may have seen advertised before. Very common drug. This is, the generic is tamsulosin. And so the thought is you inhibit smooth muscle contraction. So it's again to kind of relax the smooth muscles in here and help relieve obstruction or resistance to urinary flow. So if we get into prostate cancer, this is malignant. It's proliferation of prostate glandular tissue. From a pathology standpoint, this is an adenocarcinoma. If you're just taking histology or anatomy, this is just extra clinical information. Kind of keep it in your back pocket, but definitely important if you're taking a pathology course. You may see these used interchangeably: prostate cancer, prostate adenocarcinoma, same thing. Very, very common cancer in men, especially elderly men. Most often occurs in the peripheral and posterior region of the prostate. So again, you can see why these lobes are important. So they may not necessarily be on an exam, but again, it helps you differentiate. So again, if we draw the urethra here, we'll mark an X there so you don't think it's a lobe. So you've got the urethra there. You've got the anterior lobe here. You've got these lateral lobes. Let's just say lat. You got the middle here, let's say mid. And then posterior here, post. And then actually, the rectum is just posterior to the prostate. So that's why to screen for prostate cancer, you'll do a digital rectal exam in addition to measuring the PSA. Now, what's important about the location is if the tumor is back here in the posterior aspect, Again, when you press on the posterior aspect of the prostate, you can feel this bump, and digital exam is actually pretty good about detecting, especially if it's in the posterior aspect. And so that's why it's important to note the location of prostate cancer typically being in the posterior region versus BPH being more periurethral. The unfortunate thing is if prostate cancer can cause urinary symptoms similar to BPH, the problem is then it's gotten so large. At that point, it's not good because it's a larger tumor, and you've allowed it to grow for longer, and then you have increased risk of patient having metastasis. Speaking of metastasis, prostate cancer frequently metastasizes to bone, especially the lumbar spine and the pelvis. It's regionally there. Treatment-wise, you give hormone therapy, which essentially you cut down on the production of testosterone. This is actually called chemical castration. You can give radiation therapy, which is actually really good at treating prostate cancer, especially if it's early stage where it's just localized to the prostate gland. Hasn't metastasized. Surgery is really, really good. Both of these are really, really good at treating early prostate. This would be a prostatectomy, which is in the name, removal of the prostate. That can be done either open, laparoscopically, or frequently these days you see it done robotically, which is pretty cool. And so that has really good outcomes as well, especially in early. The 5-year survival for prostate cancer is actually close to 100% if it's caught in the early stages and treated with either surgery or radiation. You can also give chemo if that's necessary, in addition to surgery and or radiation. And especially if you've gotten to the metastasis, that's where survival goes significantly down. Then in those stages, definitely you're going to need more systemic therapy with chemotherapy. Erectile dysfunction. This is the inability to develop or maintain an erection during sexual activity. Causes: cardiovascular disease, often a cause of this. Again, remember, getting an erection is dependent on having good blood flow. So if you've got significant cardiovascular disease or atherosclerosis of your peripheral vessels, that's going to potentially limit blood flow and could lead to erectile dysfunction. Diabetes, remember, can affect blood vessels, especially peripheral blood vessels. So that can affect blood flow as well. Can be neurological if there's any kind of nerve damage, if you've had like pelvic surgery, for example, a prostatectomy. Unfortunately, that can be a complication of getting your prostate taken out for cancer. There's certain techniques that help try to preserve the nerve and prevent erectile dysfunction from happening. But again, it's always a risk with that surgery. You can also have hormone deficiency. That's mainly decreased testosterone. Drug side effects, those can be drugs that affect hormone levels or affect blood flow. It could also be psychological. So there can be no real physiological cause. It can just be all in their head. And in those cases, you need more of psychological or therapy treatment to help with that. As far as a physiological medication you give, phosphodiesterase 5 type inhibitors. And these are this is what Viagra is. Very common drug, or sildenafil is the generic name of that. And this inhibits cyclic guanosine monophosphate breakdown. So it inhibits the enzyme diesterase 5, which would break down cyclic GMP. So phosphodiesterase 5 is an enzyme that breaks down cyclic GMP into GMP. So if you inhibit this, you're going to increase the levels of cyclic GMP, and those actually stimulate smooth muscle cell in blood vessels relaxation. And then relaxation of those vessels leads to dilation. So that's how it works. Essentially, you give this drug, you help maintain cyclic GMP, helps dilate the blood vessels within the erectile tissue of the penis, helping you get that engorgement of those veins and helping you maintain an erection. It's actually a very effective drug. All right, so that closes out the fourth and final lecture for histology of the male reproductive system. We also have a corresponding lab video for the male reproductive system histology as well, which is linked in the description below.